It's my second year here at the Medicine X conference, and I just want to say, it's a real pleasure to be here because I think a lot of you don't actually either understand or fully appreciate some of the challenges that we in government have when it comes to innovation, use of technology, some of the problems that keep us up at night. For purposes of just background and introduction, this is my third time serving at this department in the state of California. I have served under two governors, both Schwarzenegger and Brown. The department has an annual budget of approximately $94 billion, 4,000 employees, and we currently serve about 14 million Californians, about 1 in 3. So at night, when I lay awake, I have a multitude of issues that I think about. But one of the things that has really been part of my intentional leadership and efforts around the department is how do we use data to make better decisions, and how are we kind of embedding certain processes and administrative actions that put the program on a path of sustainability in the future. Obviously, because Medi-Cal is tied to economic realities in the state of California, when we have recessions, Medi-Cal actually goes up, which is the time in state budgets when you have the least amount of resources to actually put into that program. And so under the Schwarzenegger administration, when I was there in 2008, 2009, we had a deficit of $60 billion. And so when you think about the fact that the department has a general fund budget of about $18 billion and your total state deficit 60, you can start to understand some of the problems that we struggle with every day. And so I had appeared last year and used some of Jim's slides to kind of introduce the department, introduce the program, introduce the challenges, but I wanted him to actually come and present to you today some data that we've been working on as it pertains to some of our aging population. And so when you think about innovation in government, we have a lot more rules, we have a lot more things that challenge us. I think, and I've worked in the private sector, some of your challenges around innovation and how you grapple challenges can by and large be solved with money and time. In government, we have a lot more constraints, and so we're forced to be a lot more creative when it comes to being innovative, and that may be frustrating for some, but I think in some cases that's what makes it so much more unique and more rewarding, especially when you're able to see something to fruition. So with that, I will let Jim walk his way through our slides.
Thank you, Jennifer. Good afternoon, everyone. So today I'm going to give you sort of a panoramic view of Medi-Cal. Medicare is going to be a part of this, and also the state budgeting and the federal budgets, because we're closely tied when you think about these programs. So if at the federal level, if you have deficits, that can be problematic for the state, and of course you know that the state has to balance its budget, so it's even more complex when they make changes. So we'll start out the Medi-Cal program, give you a little background, so you think of it as the low-income program, but it's much more than that. It's changed with the ACA. We're bringing in populations ages 19 to 64, where we're basically just looking at income up to 138% of the federal poverty level, so that's sort of changing the flavor of the program. Years ago, it was deprivation and some other real requirements where you thought about women and children and the disabled. We're the primary insurer for the disabled populations and some clinically complex conditions that generally are not insured when you look back, like hemophiliacs and some other conditions. Foster care children, pregnant women, and individuals with special health care needs. Today we have 13.5 million eligibles. I don't think anyone could have imagined that this number would grow this large. If you saw some estimates from the UC, they had it nowhere near this number, which is historically, we've generally underestimated these major expansion programs, both at the federal and state level. That's about 34% of the population. We pay for 50% of all the births in the state, so it's about 500,000 births, 250,000 we're actually financing. We have some special programs there for pregnant women. We insure about 6 out of 10 children, 0 to 17. In actually some counties, 80% of the children are on Medi-Cal, so some places in the Central Valley. About a quarter of those age 65 or over are insured in the program. And so it varies by age group. And this is actually changing too as we expand the program. I always like this map here. When you really look at it, you can see the Central Valley are the areas with the highest Medi-Cal penetration rate. So 50% of everyone that lives in that county is enrolled on the program. Down south, it's pretty high, and up north. And these are interesting when you look at, sort of overlay this and start looking at children. There's some real dynamics in some areas about how many children that we insure. I mean, it's as high as 100% in some geographic regions. Oops. Can't forward the slide here.
Slow and steady.
Yeah.
Maybe you can wish it to move forward. They liked the map so much they just wanted to keep
Kind
it
of
there.
stuck. Well.
Can we get a tech assist on slide advancements?
Yep.
Okay, they're on it.
Well.
Give them a preview.
Yeah, hopefully. Yeah, we're going to talk about a $90 billion budget here. $57 billion coming from the federal government, and you're going to see some changes on how that financing mix has changed over the years, and it'll be fairly surprising.
I think to the financing part, for people's just overall perspective on the department, our weekly check write for fee-for-service providers runs around $400 million a week. Our monthly capitation payments to our 21 contracting health plans is $3 to $4 billion a month. So just from a scale and perspective, that helps you understand what we push out the door.
Well, here we go. And since we're talking about the aged, we finance about 65% of long-term care, and these are the institutions. Long-term care has a broad definition. Long-term services and supports can include care within your home, like in-home supportive services, and we finance a significant proportion of that as well. So we're going to move to state financing now. You may know that this is the most complex budget in state government. If you've ever seen the estimate binder, at one time I used to do that estimate, and it was really a nightmare. It's about 4 or 5 inches thick with many, many policy changes, and it has really some complexities to it. So you've probably seen these things in the paper where it says the Medicaid budget is eating up the state budget. We're going to go broke. Well, we've been looking at this for 15 years and actually doing predictions 15 years ago, working with a professor here, and we've never come to that conclusion, although we do see that we have to make changes in the program. So some of it's alarmist sometimes, but here's a picture of the financing of the program. So we start in state fiscal year 2007-8, moved to 2016 and 17. And one of the things you'll really notice here is the uptick in that orangish yellow line there, which is the federal funding. And you'll see that this really jumps, and it jumps at 2 points. When you look back at, say, 9, 10, 10, and 11, we had some federal funding that helped the states during the recession, right? So what they did is provided additional funding to the states. Generally, it's a 50-50 match, but it changed it to, say, 60% they were paying for. So that was the first major shift. And then the other shifts happen in the later years here. You can think about the ACA, which the population is 19 to 64. The federal government is paying for 100% of the medical costs for that population out to 2020, when it gradually reduces down to 90%. If you look at the green line down at the bottom, you'll see there that's the state general fund, and it's relatively flat. So those are, you can think of that as our tax dollars and broad-based taxes. That hasn't changed much, but the two lines, the federal, which is the yellow, and then that red line at the bottom, which are special taxes, so provider taxes, which essentially is taking money from someone other than the state's general fund to help pay for the program. So we get a federal match. We give $1, they give $1. So that's what's happening here. So the big point is the federal dollars. Here you can see in 2007-8, the state dollars, it was about 39% of the funding. That's dropped to 20% today. So the federal dollars has risen from 59% to 64%, and then the special funding up at the top is 16%. And this will be important as we work through it and talk about the federal budget. So we're about 14.5% of the state's general fund spending. Still education, if you see it, there's about 42% K-12, and in higher education is about 12%. So those are the giant ones. And a lot of that has to do with the fact that they don't bring as much federal funding into the state as the state Medicaid program does. And here's just to show you the percent of the general fund that Medi-Cal is. And you can see it's relatively flat. In fact, it's dropped in the outer years. We're about 14% nationally. It's 14, 15% and some 18% in some states. So we're right in line with what you see in the national numbers. In terms of the state's overall spending, if we took the federal, state, and other funds, we have a budget of almost $400 billion. We're about 23%, $90 billion. That's 16, 17. So the major takeaways here, we're insuring 34% of the population. In terms of kids, we're up to 60%, 50% of the births, and about a quarter of the age population, which is, if you think about the aging of the population, there's going to be some major changes here as we look forward. Federal contribution, 65%. And so, again, looking to the future, we're highly leveraged with the federal dollar. So what the federal does truly impacts how we deliver services down the road. So we have to talk about federal funding because the program, we share the program with the federal government. They pay 50%, we pay 50%. And some populations much higher. So you've probably seen this. I think the CBO numbers out in August. They're predicting the return of trillion-dollar deficits out in 2024. Even if these predictions are wrong, which I really don't, I think we're going to see this into the future, but the three programs in healthcare, Medicaid, Medicare, and the Children's Health Insurance Program, and some of the subsidies in the ACA are really driving these deficits. So if you look at it, about 82% of it is coming from the major health programs, which is the three that I just described, Social Security, and net interest on the debt. So entitlement reform that you hear is certainly going to be something that we have to look at because the grants to the state, it's expected that we're going to spend $1 trillion out into these estimates just on the Medicaid program, up from about $400 billion. So the debt as a percent of GDP, you've probably seen this too. We're at levels that we haven't seen since World War II. The prediction into the future is much, much higher as well. And even if that prediction there is slightly off and it flattens out, we still have some complicated issues to deal with when we think about the future as it relates to the aging of the population and these healthcare programs. So the takeaway here is the Medi-Cal program we know is highly dependent on federal funding, and then these policy changes at the federal level. If they change something, it's certainly going to impact us because they're paying for 60% of the bill here, and for some populations, even a greater amount. So into the future, both the federal, state, and all the stakeholders around Medicaid are going to have to really look at how we manage the program with the influx of the aged population, and we're going to get to that right now. So what we're trying to do here is envision what it actually looks like. So we talk about the age, but how do we spend the money? What do these populations look like in Medi-Cal? So what we're doing here is we're going to look at federal fiscal year 2013-14. These are actual dollars that the state spent, minus a few things like administration. So the first thing we're going to look at during federal fiscal year 13-14, there were 12.9 million eligibles in the program. They were eligible for at least 1 month. And the spend was $87 billion. And this was a combined Medi-Cal dollars as well as the Medicare dollars, because people in the Medi-Cal program can be eligible for both programs. There's about 1.3 million individuals in these programs who are eligible for both programs. We broke the population into 3 groups: aged, and I'll describe this later what it is, blind and disabled and low income. These are generally eligibility pathways. If you think back historically in a Medicaid program, you had what were called age, blind, and disabled. Those were statutory definitions for populations. And then you think about the low income, those were generally the public assistance families that were receiving services, so women and children. And the blind and disabled, for instance, might have CCS children, genetically handicapped, and some complex populations. But you can see here there's about 1 million aged individuals, 9% of the population. They generated 35% of the spending, or $30 billion. Blind and disabled, 10% of the population, about 35% of the spending, $31 billion. And then the low income, 10.5 million, 82% of the population, but only 30% of the spend on that. And then the boxes at the bottom are showing the split between the Medicare and the Medi-Cal. So one thing that you'll take note of is we spend a lot of money on the age population on the left-hand side in the blue because about 88% of that population is eligible for Medicare and not just Medi-Cal. And we'll show this as we go through. So we're going to focus on this group and drill down. And by the way, if we tried to look at this all, we would be here until the night and the next day. It really is complicated. So one of the things you'll notice here is there's more females in the aged group. This has to do with lifespan. There's no surprise there. You'll see some slides later that show that. Disabled is split about 50-50. And then the low-income population, it's sort of changing because at one time it was primarily women because the eligibility pathways were geared toward women with children. But now as we've expanded the program to bring in the 19 to 64, we're seeing a significant shift in the population, so more males in the population. If we look at age group, one thing to highlight here is among the age, 16% of those are 85 and over. If you've looked at any demographics lately, that's a population that's expected to grow, as well as all of those over 65. And those are certainly the most costly, and you will see it as we go through here. There's a few disabled children. It's very small down at the bottom. The classification there primarily is related to CCS and a few other disabled children through the SSI, SSP program. And then in the low income, the biggest bulk of the children are there, which are the least expensive in the program. In terms of eligibility for Medi-Cal and Medicare, no surprises here. Among the age, about 88% are eligible for both programs. That's what we'd expect to see when you're 65. Generally, you're going to go on to the Medicare program unless you haven't worked enough quarters and you don't qualify. We have a small subset. You can see there about 12%. Among the disabled, you can see that this is an interesting population too, although we won't talk about it today, but 31% are duly eligible, and that 69% that you see at the top, they're in the waiting period, the 2-year waiting period where they have to wait to get disability status, and then they're categorically linked or automatically linked to Medicare. So people are transitioning with that group. And then in the low income, almost no one is duly eligible. One of the things that you'll see here, and you see this in a lot of the literature among the age, the big difference is the Asian population. You can see it's about 24% of the population. There's some immigration issues that drive that and some other things, but that's the significant difference. The other thing that's interesting among the disabled is African American is about 14%. It's one of the higher groups that meet the disability status there. So again, 10% of the population, or 9% of the population generates 35% of the spending. That's the aged. That's the focus that we're going to go through. So just looking at costs, if this is a stacked area here, blue being the Medi-Cal program and the orange being the Medicare, with the red line being the number of eligibles. So you can see here, as we age, Medicare comes into play, so the dual eligible spending starts rising, but the number of people are dropping. So a smaller and smaller group is generating bigger and bigger aggregate costs. It's growing over time. You see the same thing here when you're looking at per member per month costs. Off the boards per member per month costs for the oldest individuals sort of shared between Medi-Cal and Medicare. Medi-Cal picking up most of what are long-term services and supports. If we were to look at the per member per month just overall globally, you can see the aged is about $2,400, disabled $2,200 per member per month, and then the low income about $263. These costs are combined costs, so we're looking at both Medi-Cal and Medicare. So in those cases where the people were dual, they'll have two payer sources.
And this is where I ask my favorite trivia question, Jim. What was the highest cost person in the program in that year?
Oh yeah, so we have individuals at $30 million, just one individual. So yes.
So when you think those PMs are high, we actually have people that set a standard unto themselves.
Yeah, so and many exceeding 100,000 or more, thousands actually. So this is probably no surprise to anyone. We have an aging population. You can see the steepest slopes between 2010 out to 2030. There's a number of papers written on this topic, and sort of 2030 being a crisis year, issues around will we have enough caregivers for these populations. But for us in Medi-Cal, it's a big problem when you look at the cost. So we're going to go from about 4 million individuals over 65 to about 8.4 million. And if you combine that with what's happening in the economy, we could end up with more people on our program. So toward the end, we'll touch on this. Let's see. Well, we don't have a, we're missing the, well, let's see. Well, I can just talk through this. So basically, this was supposed to be the eligibility pathways here, but the blue section, so how does someone whose age get into the program? Well, you qualify for what's called the supplemental security income. So your income is so low, you need some income to help you eat and house yourself and make it. So about 53% of the population comes into the program that way. The red and the green are special programs. We have two programs, medically needy, aged. So in that case, you have higher income, but you don't have enough income to support your medical needs. And that's the red section there. And then the green section that you see there is what's called the federal poverty level or percent of poverty aged. And so this is a special program that the federal government established and the state adopted that allows you to come into the program with higher income, and also the asset and resource requirements are sort of modified for you so that you can get into the program. Again, thinking into the future economically, as more and more seniors are ill-prepared for retirement, this means that these are doors or entryways into the program. And then that light green color there, that is medically needy long-term care, and that's probably the program that most of you are familiar with. That's the spend down program where you go into long-term care, you exhaust all your resources, and now you need someone to pay for the long-term care services, and that's Medicaid stepping up to pay for that. So Medicaid pays in many cases for custodial care when Medicare does not, and remember, there are limits on the Medicare side in terms of skilled nursing facilities, so that's a big burden to the program. So when we think about gender distribution among the age, you can see here the blue are males, and so as we age, the blue proportion is dropping, goes from 45%. By the time we get out to the 90s or so, it's 29%, and primarily females are left, and those are the primary residents in many cases of the long-term care. So it's a significant proportion of that population are females. If we looked at the aged again, we have 1 million people, $30 billion spend. We can split that into Medi-Cal eligibility. About 12% of those, or 141,000, are Medi-Cal eligible only. And then about 88% are dual eligibles. You've seen the spend already. And then the center green is long-term care services. So we have some in the institution, about 33% of the spending, 9%, and then no long-term care. And then those in the community. So those are people who need long-term care services, but they're living in the community. And we've been transitioning that way for a number of years in the Medicaid program, trying to rebalance that program away from institutional to the community. This is the cost distribution. In many cases, the cost distribution that you'd see, the top 1% would generate about 30% of the spending. This is a little less skewed here. 1% generates about 11.4%, but the per member per month cost is $26,000 there. And the top 5% generates about 30% of the spending, and it's about $15,000 per member per month. And then, of course, the bottom 50% is only about 10.6% of the spending and a much lower PMPM. In terms of spending, hospital inpatient is where we're spending our money, plus long-term care. So you can see 32% is related to hospital inpatient. Skilled nursing facilities is about 22%, and in-home support services is about 10%. So those are two areas that are really driving the cost. When you think about inpatient days in the Medi-Cal program, we have about almost 7 million inpatient days, and 9% of the population generates 33% of those, and then the disabled is about 10% of the population, but generates 35%. And then the low income, the inpatient days there are primarily related to childbirth. So the complex inpatient days are in the orange and the blue, very skewed. You can see the rates per 1,000 member months off the charts for many groups. So the age is 176 per 1,000 member months, disabled about 165. Long-term care, institutional. There's been a number of papers written on this. Literature is filled with this. You can see it's 890 per 1,000 member months. In many cases, they are in and out, and there's some incentives for that. So if we look at some of the conditions, I think no surprise here among the aged, hypertension, hyperlipidemia. I think it's interesting, diabetes is 45% of the population, so almost 50% of the population with some of these complex medical conditions. The cost per condition, you can see hip fracture, heart attack. These are $10,000 per member per month for these populations with these conditions. Note, these aren't mutually exclusive, but these are subpopulations with these conditions. Very different than what you'd see if we were looking at, say, so dementia plays a big role in here, but the disabled. One thing that's really driving costs is the concurrent medical conditions. You've probably all seen this, but if we looked at the chronic condition warehouse at the Medicare level, and we looked at these subpopulations, 40% of the population has 5 to 9 chronic conditions that are being treated. You see a number of providers, you're going to drive up the costs, and it leads to high inpatient rates and the need for long-term services and supports. So distribution of spending by for the age eligibility group by long-term care status. You can see, again, those in an institution, about 10% of the population, but generating 33% of the spending. And it's interesting, as you go through this, there are some major themes in these distributions look at the same. So small subsets of the population are driving most of the aggregate or the aggregate spending in both programs. So if we looked at combined per capita spending by long-term care status for the aged, you can see that middle bar there, long-term services and supports institutional. That's the big one, almost $100,000 a year. So this is a big problem if you think about financing long-term care for yourself. And saving for this is probably an impossibility for most people. So some future. When we think about the future, so after we see all of this, and this is what we have to struggle with. So we've got demographic trends. This is a fixed effect. We can't change that. Medicare is not free, which means we have to step in and pay for health care services, cost sharing, and co-payments. There's no long-term financing program in the nation. So if you can't save up for yourself, you're going to have to rely on Medicaid. Retirement preparation, fewer and fewer people are actually ready to retire or prepared to retire, which means into the future, who's going to pay for these healthcare costs? Federal deficits and the debt, there's going to be some changes there, and we're going to have to think about these entitlements. State budgets, we all know that it has to be balanced. Jennifer talked about budget, $60 billion budget deficits at the state level. We could run into those during an economic downturn, which makes this very difficult. And then the capacity of the healthcare system, which is a real concern for all of us. I mean, who's going to care for these people? So that's a giant one. And then we're leaving this for you, which is how can technology change some of this, thinking about these complex problems? So thank you.
Yeah. So I think what our intent was in doing this, and I always like watching Jim do these things because I tend to like data, no surprise, when I'm trying to make decisions at my level and when we're advising both the agency and the governor. But I think, the challenge to you and the whole point of us doing this presentation today is these are the challenges that we face as a program and as a state. And so it's really kind of more to put something in front of you to say, this is what we grapple with, these are the rules that we grapple with, this is the financing that we have that is set in front of us, and is there a way in which we can work together to kind of think about how we innovate as a state. I mean, government is not necessarily known for its flexibility, and I'm not here to tell you that we can be flexible, but I think that there are both interests and attempts on our side to work with others on how we kind of take on some of these challenges. And if he's here, Niles in the audience is with us as well from the California Health and Human Services Agency. He's serving as a FUSE Core Fellow for the year. And he's been tasked as part of his fellowship with setting up an innovation office within our HHS agency. So I'm one of 12 departments. And so I wanted him to come and also meet with some of you, just because I think we're always interested in how we connect with others in the private sector, both so that you understand us as government and some of the challenges that we have in working with the delivery systems that we've established, but also understanding what's being done out in the real world, as some of us would say, to help us get to a better path. So we really appreciate your time, and we look forward to talking with you later today. So thank you.